In pancreatic cancer, we actually finally had made major progress because after many years of frustrations, we had 20 years of having just one single agent as a chemotherapy for this type of disease. We're now moving into an area where the whole spectrum of treatment options is available all of a sudden. So with the advent of the new chemotherapy combinations like FOLFIRINOX or gemcitabine plus nab-paclitaxel, we have so many more options now for patients in the first-line setting, but also now we have novel options in the second-line setting. Now we have 5-FU plus NAL-ERI, for example, which has just been approved by the EMA as well. So we're thinking about sequencing of the treatment, which hasn't been the case before, and we have evidence for that. So we're not doing the best what we think it might work, we're doing what we know it works. We have evidence-based data from big trials that really work and show an improvement in overall survival. And that of course gives us the opportunity also to think further on. So treatment de-escalation, for example, we have very intense phases and less intense phases. What we've been doing in colorectal cancer for many years now. First time that we can do that and think about that in pancreatic cancer. And then of course, with the new data on the sequencing, particularly work from Andrew Biankin's group in Glasgow, we now have a better understanding what pancreatic cancer is all about and where could be the keys where we actually could tag in and then tackle the tumor more specifically. This is a little bit disappointing, I must say, because what the sequencing data showed is that pancreatic cancer is an extremely heterogeneous disease. So we have not a single tumor is the same between two patients. So we have pancreatic cancer is a very, very dynamic and different heterogeneous disease. But there are some points that actually are quite interesting and give hope to patients. And we have seen, for example, when we think about immunotherapies, that there are microsatellite unstable pancreatic tumors that may have tremendous benefit from checkpoint inhibition. On the other hand, we've seen that there is a subpopulation of pancreatic cancer, and you already mentioned the 4 groups, the chromosomal unstable tumors that have a BRCA signature. We know that BRCA mutated tumors are sensitive to platinum-based agents or PARP inhibitors, as we've seen in the ovarian cancer scenario. And nowadays, this opens up an opportunity also for pancreatic cancer. And this is, of course, not the majority. We're talking about, when we're thinking in germline tumors, about 5%. But still, this is a very interesting subgroup, and for this subgroup, we might actually have a tremendous benefit with respect to life expectancy. So it is worthwhile checking. We're entering into an area where molecular analysis of the tumor makes sense, because we can offer something to patients, and not just having an analysis that at the end of the day just gives nothing to the patient, but only knowledge to the scientist. And this is something we don't want, of course.